Okay, let's unpack this. Welcome back to the deep dive. Today, we're taking on, well, probably the single most dense, but definitely rewarding chunk of knowledge for any GP trainee prepping for their exam, Pediatric High-Yield Essentials.
Absolutely. This is a really crucial deep dive,
Yeah.
specifically tailored for those high-stakes moments in the AKT. We aren't just, reading off a list of facts. We've spent time distilling a huge stack of sources, syndromes, infections, orthopedics, acute stuff into, well, a collection of clinically decisive anchors.
Yeah, and our mission today is all about creating instant pattern recognition. Because when you're faced with a challenging vignette, maybe under pressure, you just don't have time to look things up, do you?
Not at all.
You need to be able to connect maybe three sort of disparate features, say a specific murmur, a distinct facial look, and maybe a limb deformity, and bam, immediately narrow that diagnosis down.
That is exactly the goal.
Mm-hmm.
We are focusing really intensely on the must-not-miss diagnoses, those critical age presentations that just change management immediately, and the strict adherence to management protocols that the exam loves to test.
Right.
So if you can use the age of the patients or maybe the precise location of a rash to distinguish something benign from something critical, well, you're definitely on your way.
Okay, let's jump right into the deep end then, starting with congenital syndromes. These conditions, I find, really reward absolute specificity.
Okay, let's start with structural defects, the ones that present pretty much immediately in the neonatal period. So when you see a case describing a newborn, really struggling, significant upper airway obstruction, you must look for the triad that defines Pierre-Robin syndrome.
Which is?
Right, so the underdeveloped mandible, that's the micrognathia, then the subsequent sort of posterior displacement of the tongue, that's glossoptosis, and the direct result is that upper airway obstruction.
Yeah.
It's really a mechanical consequence of that small jaw that creates the potentially life-threatening problem.
So recognizing that triad means immediate airway assessment.
It's telling.
Now, let's talk about that group of syndromes defined by short stature and often a webbed neck. Clinically, we absolutely have to contrast Turner syndrome and Noonan syndrome. They can look similar, but the underlying pathology, the cardiac features, fundamentally different, aren't they?
Oh, completely. And this is a perfect example of how the exam tests that kind of nuanced differentiation. So in Turner syndrome affects only females. Remember, 45X stuck to the short stature, the webbed neck. They're really secondary to the underlying gonadal dysgenesis.
Right.
And the endocrine hallmark is raised FSH and LH, reflecting that ovarian failure. Structurally, the common heart issues are a bicuspid aortic valve or coarctation of the aorta.
Okay, so aortic problems.
Aortic problems,
Yeah.
and because they're arterial defects, you often hear just a general systolic murmur related to that flow obstruction.
So Turner's, primarily endocrine, structural issues, leading to an aortic problem. How does Noonan syndrome differ then?
Okay, so Noonan syndrome affects both sexes. It also presents with a webbed neck, often pictus excavatum, that sunken chest appearance. But the critical, absolutely clinically decisive difference is the cardiac defect. Pulmonary stenosis.
Pulmonary, okay.
Pulmonary stenosis.
Right.
And because of that pulmonary valve involvement, the associated physical finding is an ejection systolic murmur, heard best, and this is key, at the second left intercostal space.
Ah, the location.
Exactly. The exam will probably give you that specific murmur location to force the differentiation.
That distinction, aortic versus pulmonary stenosis, and the precise spot you hear the murmur, that's where the marks are, isn't it?
Spot on. And while we're talking cardiovascular links, we have to mention Williams syndrome. This one's defined by a very specific kind of outflow tract obstruction, supravalvular aortic stenosis.
Which gives us another unique murmur location.
It does. An ejection systolic murmur again, but this time best heard at the right upper sternal border, or RUSB.
RUSB for William.
Exactly. Clinically, you'll also see features like, again, a sunken chest, maybe a specific learning disability, and crucially, hypercalcemia. That's often an early clue. You absolutely must match RUSB to Williams.
Okay, got it. Shifting gears a bit to the trisomies, these often give us those really striking limb and foot findings, don't they?
They do.
When approaching the trisomies 13, 18, 21, we should be looking for that critical limb feature. What distinguishes trisomy 18 from trisomy 13, for example?
Okay, let's start with Edwards syndrome, trisomy 18. The immediate identifiers are these complex structural features, the overlapping fingers,
Ah, yes, the fingers.
and the classic rocker bottom feet. You might also notice webbed toes. The key pattern here is severe structural malformation coupled with intradural growth restriction.
The rocker bottom feet finding, though, that's shared, isn't it, by the next trisomy?
That's right, good point. Pato syndrome, trisomy 13, also presents with rocker bottom feet. But the definitive differentiators are the triad of polydactyly, the extra digits.
Extra fingers or toes.
Exactly. And it's severe midline defects like a cleft palate or cleft lip. So if you see rocker bottom feet, the polydactyly is your sort of cognitive hook to think trisomy 13.
Makes sense. And then there's the most common trisomy, Down syndrome, trisomy 21. Beyond the classic phenotype, the round, flat face, low-set ears, the hypotonia, single palmar crease, what are the long-term clinical anchors we really need to recall for the AKT?
The complications are absolutely critical. Firstly, congenital heart defects are extremely common, particularly atrioventricular septal defects, AVSD.
AVSD.
Also patent ductus arteriosus, PDA, and tetralogy of Fallot. But the AVSD is particularly characteristic.
Right.
Secondly, the lifelong risks. Recurrent respiratory tract infections, often due to some immune deficiency, hypothyroidism, and the highly increased risk of developing early-onset Alzheimer's dementia.
Yeah, that link to Alzheimer's is such a classic teaching point, isn't it? Because the amyloid precursor protein gene is right there on chromosome 21.
Precisely. And while the AKT focuses heavily on management, you still need to remember the risk stratification context. Like for a maternal age of 45, the risk of Down syndrome jumps to about 1 in 50.
Good reminder. Okay, now let's look at the metabolic and behavioral syndromes. Here, the distinguishing features often seem to center on appetite, growth, or puberty.
Right. For Prader-Willi, the triad of presentation is essential. Severe obesity due to hyperphagia, that excessive eating, marked neonatal hypotonia, the classic floppy infant,
baby, yeah.
and hypogonadism. What's really interesting here is the shift. They often start as infants with feeding difficulties because they're so floppy, but then they transition into this compulsive eating disorder.
Which contrasts quite sharply with the X-linked learning disability, Fragile X.
Yes. For Fragile X, we look for a large head circumference, macrocephaly, and crucially, post-puberty, the development of macroorchoidism, disproportionately large tests. Given that learning disabilities are common in many conditions, that specific post-pubertal development of macroorchoidism is the key differentiator you need to spot.
Got it. Post-puberty large testes equals Fragile X trigger. And finally, a syndrome defined more by an auditory cue, Kridusha.
Yeah, caused by a deletion on chromosome 5. This is named for the distinct, very high-pitched, almost cat-like cry.
The cry of the cat.
Exactly. The clinical picture usually includes microcephaly, often coupled with severe learning difficulty, sometimes self-injurious behavior and repetitive movements. When the case describes that high-pitched cry, you just have to lock onto this diagnosis immediately.
Okay, moving from syndromes to infections, here the stakes really shift from, say, chronic planning to acute management. The primary challenge, I think, is distinguishing the benign viral exanthem from that critical systemic vasculitis that needs immediate specific drug intervention.
Absolutely. We have to begin with that critical diagnosis, Kawasaki disease. This is a medium vessel vasculitis, and if it's untreated, the risk of coronary artery aneurysms is just devastating. So we need absolute clarity on the diagnostic criteria.
Okay, walk us through it. What's the temperature benchmark and how many associated symptoms do we need?
Right. Fever. High, persistent, lasting 5 days or more. You must have that persistent fever plus at least 4 out of the following 5 criteria.
4 out of 5, okay.
4 out of 5. So non-purulent conjunctivitis, red eyes, but no gunk. Specific oral changes like cracked lips or a strawberry tongue, but distinct from scarlet fever's tongue.
Okay.
A polymorphous rash or cervical lymphadenopathy, often just a single large node. And finally, changes to the extremities, redness or swelling of the hands and feet, sometimes peeling later on.
This level of detail in the presentation, it really demands a precise response, doesn't it? Why IV, AG, and aspirin? What makes that combination so, well, unique in pediatrics where we usually avoid aspirin?
That's a great question. It really turns a memorized fact into clinical insight. So IVAG, intravenous immunoglobulin, that's given to modulate the systemic immune response, and critically, it reduces the likelihood of developing those coronary artery aneurysms.
Right. The main risk.
Exactly. High-dose aspirin is used not just for its anti-inflammatory effects in the acute phase, but also crucially to prevent acute thrombosis. Kawasaki is associated with hypercoagulability, increased platelet aggregation.
Ah. Okay.
So the aspirin helps counter that. And yes, you're right, it's unusual in kids, but vital here. And mandatory echo follow-up is essential to monitor for those coronary changes.
That makes the management much more clinically anchored.
Okay, now for the classic viral spotters, these should be quick wins based on maybe one or two distinctive physical signs.
Let's use the spots and location as our anchor. Measles means Koplik spots.
Koplik spot.
Small white spots found specifically on the buccal mucosa inside the cheek that appear before the generalized maculopapular rash breaks out. Okay, and if the rash is pretty much confined to the face, giving that classic slap cheek appearance?
That's erythema infectiosum, caused by parvovirus B19. Often spares the area around the mouth, circumoral pallor, which makes the red cheek stand out even more.
And the disease where the vesicles literally tell you the location? Palms, soles, and mouth.
Hand-foot-mouth disease, usually Coxsackie virus A16. If the vesicles are contained to those three areas, palms, soles, mouth, the diagnosis is pretty much confirmed.
We definitely need to ensure we differentiate the bacterial rash here, scarlet fever.
Yes, scarlet fever, caused by group A beta hemolytic streptococcus, same bug as strep throat. The rash is classically described as feeling like sandpaper.
Sandpaper rash.
And the tongue often presents as a strawberry tongue, similar to Kawasaki but in a different context. Unlike the viral exanthems, the management here is antibiotic therapy, usually penicillin, to prevent those non-suppurative complications like rheumatic fever.
Right, crucial distinction. Okay, let's delve into those slightly less common infections that might carry specific presentation rules or, importantly, congenital risks, like rubella, German measles.
So in the standard childhood presentation, rubella is usually mild, often features prominent occipital and posterior auricular lymphadenopathy nodes behind the ears and at the back of the head. But the critical exam hook is congenital rubella syndrome. If the mother was infected during pregnancy, the baby might present with sensorineural hearing loss, ocular issues like an absent red reflex because of cataracts, and specific cardiac defects, classically continuous machinery murmur, indicating a patent ductus arteriosus, PDA.
Okay, congenital risks are key for rubella. Then we have the infection famous for its unusual timing, roseola infantum.
This one is such a critical differentiator, you're right. Caused by human herpes virus 6B or 7, roseola follows this signature fever then rash sequence.
Fever then rash.
Exactly.
Yeah.
A high fever persists for maybe 5 to 7 days, which then breaks. The child suddenly becomes afebrile for maybe another 5 to 7 days. And only then does this faint maculopapular rash appear.
That's quite dramatic.
It is. This dramatic resolution of fever before the rash is the clinical fingerprint, and it's often associated with febrile convulsions during that initial high fever phase.
Good to know. Finally, glandular fever, often caused by EBV. There are two key management points here, aren't there? A contraindication and a diagnostic timing issue.
Yes, absolutely. The classic teaching point is that giving penicillin, sometimes mistakenly prescribed thinking it's strep throat, to a patient with glandular fever frequently results in a generalized itchy rash.
The amoxicillin rash.
Exactly. The diagnosis usually involves the triad of a persistent sore throat, significantly enlarged lymph nodes lasting maybe 4 weeks, and sometimes petechiae on the palate. Regarding timing, the monospot test, which checks for heterophile antibodies, is often negative and unreliable in the first week of illness. So testing is best performed in the second week, alongside a full blood count, looking for those characteristic atypical lymphocytes.
Right. This section feels like the absolute epitome of pattern recognition in pediatric practice, and yeah, therefore a core AKT topic. The differential diagnosis for a limping child seems almost entirely dictated by age, doesn't it? And the immediate task is ruling out those surgical emergencies.
Age stratification is absolutely the supreme pocketive shortcut here. We immediately divide presentations into the acute, systemically unwell child versus the chronic, systemically well child.
Let's anchor the acute, unwell child first, specifically those really young ones, say under 3.
Okay. If the child is less than 3 years old, looks unwell, is febrile, refusing to weight bear, and the hip is just exquisitely tender, septic arthritis has to be your presumptive diagnosis until proven otherwise.
Emergency.
Absolute surgical emergency. Because delayed treatment risks a vascular necrosis and joint destruction. The essential management is immediate admission to pediatrics. Urgent aspirate, fluids, IV antibiotics, no messing around.
Contrast that with the far more common but often confused diagnosis that frequently follows a simple cold.
You mean transient synovitis or irritable hip. This is really a diagnosis of exclusion. The limp typically follows a recent viral illness, maybe a URTI. And crucially, the child is generally, well, afebrile, and the inflammation is self-limiting.
So painful, but not systemically sick.
Exactly. While it's painful, the key differentiator is the lack of systemic illness or high fever that you see in septic arthritis.
Got it. Now let's move into the chronic, age-stratified hip pathologies. We look first at that early school age group, maybe 4 to 8 years old.
Right. Peaking between 4 and 8 years, though the range can be wider, we find Perthes disease. This is a vascular necrosis of the femoral head.
Loss of blood supply.
Exactly. It presents as a persistent limp, often painless initially, maybe some referred knee pain. Physical examination reveals movements limited in all directions, especially abduction and internal rotation.
And what are the X-ray findings we need to look for to confirm Perthes?
Well, early X-rays can actually be subtle, sometimes even normal. But later findings include widening of the joint space and eventual fragmentation or shrinkage of the femoral head due to that loss of blood supply. Management is usually non-surgical, aiming to keep the femoral head contained within the socket while it remodels.
Okay. Jumping forward now to the adolescent group, the classic picture of the often obese teen presenting with a limp.
That is absolutely the textbook presentation for a slipped femoral epiphysis, or SCFE, often pronounced SCFE.
SCFE.
Peaks between 10 and 16 years. This happens because the growth plate, the physis is weakened, often during that adolescent growth spurt, and the femoral head literally slips posteriorly and medially relative to the femoral neck.
And the management.
Because of the mechanical instability and the risk of further slippage, or even bilateral involvement, this requires urgent surgical stabilization, typically pinning in situ.
Okay. Before we move down to the knee, we absolutely must mention a critical red flag in the limping child that might suggest malignancy.
Yes, absolutely critical. Any limping child presenting with systemic symptoms, unexplained weight loss, night sweats, persistent fever, or local signs like swelling, particularly of the thigh, must raise immediate suspicion of malignancy. Think Ewing sarcoma or osteosarcoma.
I'm in the action.
This demands an urgent 2-week cancer referral pathway investigation.
Right. Okay, shifting down to knee pain diagnostics, we need to differentiate 3 really common adolescent knee pain syndromes, often just based on the specific anatomical location of the pain and the activity that provokes it.
Exactly. If the pain is localized precisely to the tibial tubercle that bump just below the kneecap, and it's worsened specifically by activities like climbing stairs, jumping, or prolonged standing after activity, that's Osgood-Schlatter disease.
The bump pains.
The bump pain.
Or pain class.
Essentially an overuse injury, an apophysitis, where the patellar tendon pulls on that growing tibial tubercle.
Okay. And if the pain is more diffuse, maybe around or behind the kneecap, and specifically related to patellar tracking worse going up or downstairs, or that classic cinema sign pain when standing up after prolonged sitting.
That points directly to chondromalacia patellae. It's irritation of the cartilage underneath the kneecap. The key is the mechanism. Increased load on the patellofemoral joint during flexion and extension.
And the third diagnosis is often indicated by more mechanical symptoms, maybe locking or swelling.
That would be osteochondritis dissecans. Here, a piece of cartilage in the underlying bone has actually detached, or is starting to detach, usually from the femoral condyle. This can lead to intermittent locking, effusion, swelling, and pain, often noted after strenuous exercise. The history of mechanical catching or locking is the distinguishing feature.
Right, the loose body feeling, okay. Finally, for ortho, developmental dysplasia of the hip, DDH. What are the 5 most critical risk factors that mean we need extra screening or vigilance?
You really need to know these off by heart for screening decisions.
Huh?
Okay. Female sex, being the firstborn child. Breech presentation, especially if it was persistent late in pregnancy. A history of oligohydramnios, low amniotic fluid. And a positive family history, particularly in a first-degree relative. Clubfoot is also a known association worth remembering.
Got them. And we must be crystal clear on the action of the 2 screening tests performed in newborns, Barlow and Ortolani. Which one does what?
Okay, simple way to remember. Barlow dislocates the maneuver, involves adducting the hip and applying posterior pressure, attempting to push the femoral head out of the socket.
Pushing out.
Pushing out. Ortolani relocates. This involves abducting the hip and applying gentle upward pressure, attempting to put a dislocated hip back into the socket. A positive Ortolani often results in that audible or palpable clunk as the hip reduces.
Barlow out, Ortolani in. Got it. Hashtag tag I5. Development, safety, and genetics principles. Okay, this next section covers 3 extremely testable areas: developmental cutoffs, critical safety advice for parents, and the rules of genetic inheritance. For developmental milestones, let's focus on those latest normal limits, the ones that should trigger a referral if they're not met.
Right, we need to highlight the absolute deadlines. For gross motor, Referral is definitely warranted if there is still significant head lag at 3 months.
Head lag at 3 months.
Sitting without support is expected between 7 and 8 months. Walking independently is expected between 13 and 15 months. The absolute red flag is not walking by 18 months. That needs referral.
18 months walk deadline.
Yeah. Running is usually around 2 years, riding a tricycle by 3 years, and maybe skipping by 5 years.
Okay. And on the fine motor side, the progression of cognitive and drawing skills often comes up in vignettes, doesn't it?
It does. The pincer grip, using the thumb and index finger, precisely should emerge between 9 and 12 months. Failure to achieve a neat pincer grip after 12 months definitely requires referral.
Pincer by 12 months.
Yeah. The drawing sequence is crucial, too. Building a tower of 2 blocks by 15 months, 6 blocks by 2 years. Drawing a circle by 3 years, a cross by 4 years, and then both a square and a triangle by 5 years.
Circle, cross, square, triangle. 3, 4, 5 years. Got it. And that really critical red flag regarding handedness.
Yes, this is a big one. Early hand preference before 12 months of age is a major red flag.
Why's that?
Well, in an infant, using one hand preferentially strongly suggests underlying weakness or neurological dysfunction on the other side. It often indicates potential cerebral palsy, CP. That finding requires urgent neurological assessment. Don't ignore early handedness.
Okay, really important point. Moving to safety critical advice, specifically reducing the risk of sudden infant death syndrome, SIDs. What are the absolute high-risk practices that must be addressed with parents?
The advice focuses entirely on the sleep environment. The most critical modifiable risks are co-sleeping, especially hazardous on sofas or armchairs.
So sad.
Very bad. Placing the baby in the prone position on their stomach to sleep. Parental smoking, both maternal smoking during pregnancy and household smoking after birth, and the use of soft bedding, duvets, pillows, or practices leading to overheating.
So the key message.
Emphasize that supine sleeping on their back in a safe, clear cot or Moses basket in the parents' room for the first 6 months is paramount, feet to foot of the cot.
Right. Okay, let's apply the fundamental rules of genetic inheritance. These often feature as pretty straightforward problem-solving questions in the AKT, don't they?
They do, and you need to be able to visually or verbally describe the transmission pattern. So autosomal dominant conditions, they tend to present in every generation. You only need one affected gene copy.
Yeah.
There's a 50% risk for offspring if one parent is affected. And they typically lead to structural defects. They get conditions like Marfan syndrome or Huntington's disease. There are exceptions, but that's the general rule.
Okay. And the characteristics that define autosomal recessive?
They often skip generations. They don't necessarily appear in every generation because the gene can be carried silently.
Yeah.
Both parents usually need to be carriers,
Mm-hmm.
and they typically cause metabolic defects. Think cystic fibrosis or phenylketonuria, enzyme deficiencies. Again, exceptions exist, like ataxia telangiectasia or Friedreich's ataxia, which are structural, neurological, but recessive.
And the probability rule we need to know. If 2 carrier parents have a child.
Right. If both parents are carriers of an autosomal recessive condition, for each pregnancy, there is a 25% chance the child will be affected, gets 2 copies of the faulty gene. A 50% chance they'll be an unaffected carrier, gets 1 copy. And a 25% chance they'll be entirely unaffected, gets 2 normal copies. 1 in 4 affected.
1 in 4 affected, 2 in 4 carriers. Got it. For the sex-linked conditions, the critical rule for X-linked recessive is all about transmission, isn't it?
Absolutely. Only males are typically affected because they only have 1 X chromosome. If they inherit the faulty gene on their X, they express the condition. Females usually need 2 copies to be affected, so they are mostly carriers.
And the key transmission point.
There's absolutely no male-to-male transmission.
Yeah.
An affected father cannot pass the condition to his sons because he gives them his Y chromosome.
Right.
He will, however, pass the carrier gene on his X chromosome to all of his daughters, making them carriers.
Okay. Finally, the unique, exclusively maternal transmission pattern.
That defines mitochondrial inheritance.
Mm-hmm.
Because the sperm contributes virtually no cytoplasm and therefore no mitochondria to the zygote, these conditions are passed solely through the mother, via the egg's mitochondria.
So inheritance pattern?
All children, male and female, of an affected female will inherit the condition, or the predisposition. But critically, only her daughters can pass it on to the next generation. An affected male cannot transmit a mitochondrial condition. #TAG-V. Acute respiratory and GU management protocol.
Okay, now we're entering the realm of strict clinical protocols, asthma, and urinary tract issues. Areas where adhering precisely to guidelines is definitely the testable knowledge. Starting with asthma, we absolutely must be able to define severity immediately in an acute attack.
Yes, defining severity is the critical first step in acute management. We need to lock down the criteria for life-threatening asthma. These include objective signs like SpO2 saturation less than 92% on air,
Under 92%.
or a peak expiratory flow, PEF, less than 33% of the child's predicted value or their personal best. And then there are the really ominous clinical signs. A silent chest, no wheeze means no air entry.
Scary sign.
Very scary. Altered consciousness, confusion, exhaustion, or cyanosis. Any of those spells life-threatening.
Okay. In the pre-hospital setting, or maybe immediate primary care, what's the crucial initial intervention before even thinking about nibs?
The critical first step is high-dose, short-acting beta-agonist delivery via a spacer. The standard protocol is often 1 puff every 30 to 60 seconds, up to a maximum of 10 puffs.
10 puffs via spacer.
Yes. And if control is not achieved after that initial round, you must repeat the entire 10-puff cycle before or while arranging admission to secondary care. Don't undertreat with the SABA initially.
Got it. Once admitted, or if the severity dictates immediate escalation, what's the sequence of medications and, briefly, their rationale?
Okay, the sequence follows a strict hierarchy based on guidelines. First, oxygen, obviously if SATs are low. Then a salbutamol nebulizer, usually 2.5 milligram or 5 milligram depending on age.
Beta agonist first.
Then add an ipratropium bromide nebulizer, usually 250 or 500 micrograms. That's an anticholinergic, helps block vagal tone, contributing to bronchospasm.
Salbutamol plus ipratropium nebs.
Yes. And then systemic steroids. Oral prednisolone is standard, or IV hydrocortisone or methylprednisolone if they can't take oral or are very severe.
And concerning steroids, what's the standard duration we're looking at for these acute exacerbations?
Systemic steroids, like prednisolone, should be administered for a short course, typically 3 to 5 days. The aim is to reduce the underlying inflammation and prevent early relapse. The dose is usually 1 to 2 milligicalabers per day, up to a maximum of 40 milligram daily for older children.
3 to 5 days. Okay. Now switching to non-acute ongoing asthma management, specifically in patients over 12 years old, the diagnostic process involves specific objective tests, doesn't it?
Yes, diagnosis in this older group looks for clearer objective signs of airway hyperreactivity and inflammation. This includes measuring fractional exhaled nitric oxide, or FeNO. A level greater than, say, 50 parts per billion often indicates underlying eosinophilic inflammation.
FeNO over 50.
Or demonstrating significant variability in peak expiratory flow rate, PEFR, maybe more than 20% variation between readings taken over a couple of weeks. Or positive bronchodilator reversibility testing.
Right. And the step-up ladder for control often utilizes the concept of MART these days.
Yes, MART maintenance and reliever therapy. This approach uses a single inhaler containing both an inhaled corticosteroid, ICS, and a fast-acting, long-acting beta agonist, specifically formoterol, for both daily maintenance and as-needed relief.
Single inhaler for both jobs.
Exactly. The latter typically starts with using this combination inhaler just as needed, PRN, for mild and frequent symptoms. Then it steps up to regular low-dose MART, once or twice daily plus PRN, then moderate dose MART, and so on. It simplifies things for patients and ensures they always get some ICS when they use their reliever.
Makes sense. Okay, addressing other common airway issues, how do we manage the classic croup presentation, the barking cough?
Right. Croup laryngotracheobronchitis, identified by that characteristic barking cough in inspiratory stridor, usually caused by a parainfluenza virus. Management is pretty straightforward, but importantly age-sensitive. You must admit if the child is less than 3 months old, or if there's diagnostic uncertainty or significant respiratory distress.
Admit under 3 months.
Yes. And for all children presenting with croup, regardless of severity, the standard treatment is a single oral dose of dexamethasone, usually 0.15 milligiacalarium, to reduce airway edema and symptoms.
Single dose Dex for all. Got it. And the most common cause of stridor in infancy, the one that often resolves spontaneously.
That's laryngomalacia. It's characterized by congenital flaccidity of the supraglottic structures. The bits above the vocal cords are a bit floppy.
Floppy larynx.
Pretty much. It causes an inspiratory stridor, usually worse when feeding or agitated. In infancy, that typically improves and resolves naturally by 18 to 24 months as the structures mature. If the baby is symptomatic during an episode, parents are sometimes advised to gently hyperextend the neck slightly to help open the airway, but mostly it's reassurance.
Okay. What about pertussis, whooping cough? The public health implications here are huge, aren't they?
Absolutely. The diagnosis requires that paroxysmal cough bouts of coughing, often followed by the characteristic inspiratory whoop, though that's not always present, especially in infants. The cough must last more than 2 weeks, and post-tussive vomiting is common.
And management.
Management is critical for containment. Macrolides, like azithromycin or clarithromycin, are given not only for treatment, though they mainly reduce infectivity rather than symptoms unless given very early, but also crucially for household contact prophylaxis, especially if there's a vulnerable infant in the house.
Prophylaxis for contacts.
Yes, the child must be admitted if they are less than 6 months old due to the risk of apnoea. And they need to be excluded from school or nursery until they have completed 48 hours of appropriate antibiotics, or for 14 days from the onset of the cough, if untreated.
Exclusion periods are key. Okay, moving swiftly onto urinary tract conditions. Again, age seems paramount for referral urgency.
Absolutely. If a child presents with a suspected UTI and is under 3 months of age, they need immediate referral and usually admission for assessment and likely parenteral antibiotics due to the risk of urosepsis.
Under 3 months, immediate referral.
Definitely. For older children, say 3 months and above, first-line oral treatment is often trimethoprim or nitrofurantoin, depending on local guidelines and resistance patterns. A crucial point is reassessment if there's no clinical improvement within 48 hours.
Okay. When is an urgent USS ultrasound scan mandatory during the acute infection itself, rather than later?
An urgent USS, meaning within 24 hours, is generally indicated if the child has an atypical UTI or if they are under 6 months of age with their first UTI, even if it seems typical because their anatomy is still developing.
And what defines an atypical UTI? What are those indicators signaling higher risk?
Atypical indicators include failure to respond to suitable antibiotics within 48 hours, poor urine flow, a palpable abdominal or bladder mass, which could suggest hydronephrosis or an obstructed kidney, raised creatinine, indicating impaired renal function, or if the UTI is caused by a non-E. coli organism or if the child is systemically septic.
Got it. And even if the UTI seems typical and responds well, any child under 6 months still needs follow-up imaging, right?
Yes, that's correct. Any child under 6 months who has had a UTI, even if they responded promptly to antibiotics, should still have a routine USS performed within 6 weeks to assess the renal tract anatomy for underlying issues like vesicuretic reflux or structural abnormalities.
Okay, 6-week follow-up scan for under 6 months. Finally, enuresis bedwetting. What's the definition age and what's the management hierarchy?
Right. Enuresis is defined as involuntary urination, usually nocturnal, that persists after the age of 5 years, when bladder control is typically expected. Management should always begin with non-pharmacological steps.
Like what?
Addressing underlying causes, first especially constipation, which is a common contributor, or ruling out UTI. Then ensuring appropriate fluid intake plenty during the day, but reducing it an hour or two before bed. Regular daytime toileting routines. And importantly, using positive reinforcement like a reward system or star chart for dry nights. Avoid punishment.
Makes sense. If those fail, what's the first-line device or drug intervention?
The evidence-based first-line treatment for persistent nocturnal enuresis is the enuresis alarm. These devices have a sensor that detects moisture and triggers an alarm to wake the child, conditioning them over time to recognize the sensation of a full bladder and wake up.
The alarm first.
The alarm first, yes. Desmopressin, which is an analog of vasopressin and reduces nighttime urine production, is generally reserved for situations where the alarm has failed after several weeks, or perhaps if it's refused by the family, or specifically for short-term relief, like for sleepovers or school trips. It's not usually the first-line long-term solution.
Okay. And just quickly, the red flag features for Wilms tumor.
Yes. The key triad for Wilms tumor, a kidney cancer in young children, is usually painless hematuria, blood and urine, a large, non-tender abdominal mass felt on examination, and maybe flank pain or fever. This combination demands an urgent pediatric referral, typically under the 2-week wait rule, which often means seeing a specialist within 48 hours in practice. #tag cities, NeoGI, and jaundice.
Okay, we're nearly there. Let's conclude with the highest stakes neonatal surgical emergencies. Here, rapid diagnosis based on history and especially X-ray findings is potentially life-saving, and we'll touch on jaundice assessment too.
Absolutely critical area. For acute, forceful projectile vomiting in an infant, usually non-bilious, the classic mechanical obstruction to think of is pyloric stenosis.
Projectile vomiting.
Projectile vomiting. Look for the classic history. Non-bilious starts around 3-6 weeks of age, often getting worse. The baby is typically hungry after vomiting. And the key physical sign, if you can feel it, is the palpable olive-shaped mass in the right upper quadrant.
The olive. Got it. Now, bilious vomiting green or dark yellow in a neonate is always a surgical red flag until proven otherwise. How do the X-ray signs help differentiate the level of obstruction?
Okay, Billy's vomiting is serious. If it's associated with a history strongly linked to Down syndrome, remember that association and the abdominal X-ray shows a distinct double bubble sign.
Double bubble.
That's gas in the stomach and the dilated proximal duodenum with no gas beyond. That points strongly to duodenal atresia. It's due to a failure of recanalization of the duodenum during development.
Okay. And if the obstruction is a bit further down, maybe in the jejunum?
Jejunal atresia can also cause bilious vomiting. The X-ray might show multiple dilated loops, sometimes described as a triple bubble sign, though it can be more variable. There's an interesting, though perhaps less common, link sometimes mentioned in sources with maternal cocaine use during pregnancy, leading to vascular disruption causing the atresia.
Interesting link. And the truly critical, time-sensitive surgical emergency that can lead to rapid bowel necrosis if missed.
That has to be malrotation with volvulus. This presents with acute onset bilious vomiting, often significant abdominal distension, and the baby looks unwell, maybe shocked. The terrifying X-ray finding here is often a gasless abdomen below the stomach, or maybe abnormal positioning of bowel loops.
Gasless abdomen.
Because the bowel has twisted on its mesenteric axis, cutting off its own blood supply. This requires immediate operative intervention to detort the bowel before it dies.
Urgent surgery. Okay. What defines Hirschsprung disease, which is more of a functional obstruction?
Hirschsprung is characterized by failure to pass meconium within the first 24-48 hours of life, and then chronic constipation from birth, often with abdominal distension. It's caused by the developmental failure of the parasympathetic nerve plexuses, the Auerbach and Meissner's plexus in the distal colon, meaning that segment can't relax.
No nerve cells.
Exactly. The segment is a ganglionic. The gold standard for definitive diagnosis is a rectal biopsy demonstrating the absence of these ganglion cells.
Right, biopsy needed. And the GI issue that's really strongly linked to cystic fibrosis.
That's meconium ileus. This is where the meconium is abnormally thick and sticky, causing a blockage usually in the terminal ileum. So again, failure to pass meconium in the first 24-48 hours in a newborn. This is strongly associated with cystic fibrosis, often linked to the delta F508 gene mutation. It's frequently the very first presentation of CF and might require a contrast enema both diagnostically and sometimes therapeutically to try and shift the blockage.
CF link is key there. Okay, a quick assessment of jaundice. Pathological versus prolonged. How do we define them simply?
Okay, pathological jaundice is defined primarily by its timing. Any jaundice appearing within the first 24 hours of life is considered pathological and needs immediate investigation.
First 24 hours equals pathological.
Exactly. Common causes include rhesus or ABO incompatibility, hemolysis, G6PD deficiency, or congenital infections. Prolonged jaundice, on the other hand, is defined as any jaundice persisting after 14 days of life in a term baby, or 21 days in preterm. This requires a full prolonged jaundice screen, crucially including splitting the bilirubin into conjugated and unconjugated fractions to rule out serious causes like biliary atresia.
Rule out biliary atresia. Got it. Finally, managing the very common issue of reflux, gastroesophageal reflux, or GER. What's the step-up management before reaching for medication?
Management absolutely must start with simple conservative measures, ensuring the head of the cot is elevated, maybe 30 degrees, reviewing feed volumes to prevent overfilling the stomach. A rough guide is no more than 150 millirokilog a day, and offering smaller, more frequent feeds can often help. Burping well, too.
Conservative steps first, if those fail.
The first escalation is usually a trial of thickened formula, either pre-thickened formula or adding a thickener to express breast milk or standard formula. If that doesn't work, the next step might be a trial of an alginate preparation, like Gaviscon Infant, which forms a raft on top of the stomach contents.
Thickeners or alginates?
Yes, but critically, you must not use alginate simultaneously with a feed thickener, as that combination can lead to excessive thickening and potentially cause impaction or instussated milk curds. It's one or the other.
Good point. Don't mix them. And when are PPIs, like omeprazole, actually indicated?
DPIs are generally reserved for more severe cases, or where there's suspicion of actual esophagitis. The strict indications are usually unexplained feeding difficulties, like refusal to feed, distressed behavior during or after feeds, or, most critically, evidence of faltering growth despite adequate intake. Simple happy spitting doesn't usually warrant a PPI. #tag outro.
Wow, okay. That was an absolutely essential deep sweep through the pediatric knowledge you really need for clinical practice and, of course, for the AKT exam. We've covered so much. from differentiating those subtle cardiac defects and syndromes to the really clear age-based management hierarchy of the limping child and those non-negotiable protocols for things like acute asthma and UTIs.
Yeah, I think the critical takeaway really is that the AKT rewards instant pattern recognition and strict adherence to protocols. Hopefully, you now have the necessary hooks, the double bubble sign, the post-puberty macroorchidism in Fragile X, the fever then rash timing in roseola, the 48-hour referral time for suspected Wilms, those triggers to help you recall these complex facts quickly and accurately when the pressure is really on.
Absolutely. We've tried to translate that huge, dense stack of knowledge into focused, actionable clinical insight, hopefully giving you a substantial cognitive advantage on exam day and in practice.
Indeed. And maybe let's leave you with this final provocative thought to consider. Just reflect for a moment on why age is almost always the single most critical determinant in nearly all urgent pediatric management decisions we've discussed.
That's a great point.
Think about the presentations we covered: UTI, croup, even undescended testes needing referral by 6 months. It is always a specific young age cutoff, usually under 3 months or under 6 months, that mandates immediate admission or investigation. Consider the underlying physiological vulnerability, perhaps the inability to effectively localize infection, the immature immune response, the rapid potential for deterioration. Understanding that reasoning behind the age cutoffs really underpins the whole SafeGenet approach of pediatric care, something to mull over.